Welcome to CCED Seminars, the worldwide destination for online chiropractic CE. You're about to begin a professionally produced, evidence-based chiropractic continuing education journey designed to support clinical excellence, license compliance, and lifelong learning. Let's begin now.
Thank you for taking time out from your busy schedule. As I'm sitting here thinking about getting up tomorrow at 5:30 in the morning to catch a flight to, of all places, Houston, Texas, to attend the ACA Council on Nutrition Symposium. Well, here we are tonight. So when Dr. Horn asked the faculty about offering technique, it immediately came to mind that I would want to talk about myofascial pain syndrome and trigger point therapy. So as a show of hands, how many doctors or students in the audience use myofascial techniques in their practice? As a show of hands. Oh, so a lot of you. That's great. So we have a lot of great information to share. As Dr. Horn said, yes, I did graduate chiropractic college in 1976. And when I was a student at National, I really didn't go into other types of manipulations other than, or spinal mobilization techniques. I mean, I took a course in AK, and that just didn't, my undergraduate degree was in mathematics. I just couldn't put my head around it. But I was lucky enough to attend a seminar that was put on by a chiropractor from Texas, Dr. Raymond Nimmo, who came to National and talked about myofascial pain syndrome and trigger point therapy. I was then able to attend a seminar that was done by Dr. Janet Travell, who is, I would say, the grandmother or the founder of myofascial pain syndrome and trigger point therapy. And it was just something that fascinated me. And I started to use that, and I still use it in my practice today. And I find it a very good adjunct to spinal manipulation and integrating it with nutrition. As a diplomate, a big part of my practice is clinical nutrition. So we want to talk about this in the domain of, we've all seen patients in our practice that have come in with musculoskeletal complaints that probably do not have a true orthopedic origin. And that's where myofascial pain and trigger point therapy comes in. So we're going to spend some time, obviously, in the next 2 hours. We're going to talk about what is myofascial pain and trigger points and how does it present in a clinical setting. We're obviously going to focus in on inflammation and the resolution of inflammation. If you've taken any of my other classes, I think it's important for us to understand that what we're talking about when we're talking about inflammation, and just about every patient you see in your office is dealing with some inflammatory process going on that actually has never been resolved. There might be a reduction in inflammation, which is actually an immune problem. Inflammation is part of the innate immune response. But if inflammation isn't resolved and the patient brought back into homeostasis, you get non-resolution. And we need to think more about moving away from doing things that simply reduce inflammation, the redness, the swelling, the stiffness, the restriction in range of motion, all of the things that we talk about when we talk about inflammation. But do we really understand what's happening? And especially with what's going on in the world over the last 2 years, understanding inflammation and what it is, and basically how we can go about resolving inflammation is important. We're going to talk about the anatomy and physiology of myofascial pain syndrome. We're going to talk about the assessment and identification. And some of the treatments that are available that hopefully many of you in your practice do, maybe some of you don't do this, but it might be very interesting. And then to look at some nutritional supplementation that might be helpful in managing patients with myofascial pain syndrome, and differentiate, because sometimes myofascial pain syndrome becomes confused with chronic fatigue syndrome. And patients who have chronic fatigue syndrome or fibromyalgia have other symptoms that are not present in myofascial pain syndrome. So patients with fibromyalgia also deal with anxiety, depression, sleep disorders, whereas patients with myofascial pain syndrome, although they may be having that because of the chronicity of their problem and not been, properly evaluated and treated, it really is separate from looking at fibromyalgia. But what we're beginning to see more and more in the literature, and this should be no surprise to anyone, the important role that prolonged inflammation plays in neuroinflammation, and ultimately that neuroinflammation leading to neurodegeneration, and ultimately leading to alterations in gut function and dysbiosis in the gut. And this has been a thing that I've spent a lot of time over the last several years trying to get a handle on, how the gut communicates with the immune system, the nervous system, and the endocrine system. And I always make it a big thing to talk to chiropractors when I lecture that if we're going to be, masters of the nervous system, we should be aware of how does the gut and the microbiota communicate with the immune system. And you'll see, I should say the nervous system, and you'll see the part that plays, obviously, in managing myofascial pain syndrome patients. So Janet Travell, for many of you who may not be familiar with her, was John F. Kennedy's personal physician. And John F. Kennedy had suffered a back injury when he was in a plane accident and suffered his whole life with back pain. And Janet Travell was his personal physician and treated him with myofascial pain techniques, some of which we're going to talk about tonight. I just thought if we're going to talk about myofascial pain syndrome, at least on the cover slide, those two excellent books. How many doctors in the room own copies of Janet Travell's textbooks? Anybody? A couple of hands going up. Good. If this is something that, there are tons of books written on trigger point therapy and myofascial pain syndrome, and certainly lots of different articles. But if you're really going to get serious about the work, I think there are two things that you should have. One is you should have these two books, which are the focus or the foundation of myofascial pain syndrome. And I certainly have them in my office, and that would be one thing. And number two, I'm going to share with you an app that you can put on your iPad that I have in my office. That is, I think it costs like $2, which is an excellent app to show patients where trigger points are located, what you're trying to do when you're treating them. And I think people have become very visual, so they want to see it and have it. And when they see it, they can understand what you're doing.
Dr. Howard.
So we know, yes.
Yeah, can I just interrupt for a moment? We have a couple of doctors that are having some issues with the presentation going in and out. If you're having that issue, please make sure you don't have anyone else on your bandwidth in your home. If you have other people streaming information, that could cause problems. Or if you don't have broad bandwidth, that can create problems as well. So if that doesn't solve the issue, then log out, log back in, and see if that helps. If not, chat me again. Dr. Howard, go ahead and carry on. I'm sorry to interrupt.
Okay, great. So obviously we should all realize or know by now that pain is a major, problem in the United States today, not only acute pain, but chronic pain. And, estimates are that 80% of the American population will at some point in time suffer from some type of musculoskeletal pain. And I think where this has really ballooned out more and more as far as a therapy is for patients who see, for doctors who see patients who have been involved in motor vehicle accidents, and certainly treating any type of athlete, whether it's a professional athlete, weekend athlete. And certainly I see a lot of patients in my practice, and it shouldn't be any different, who have experienced what I refer to as, or in the literature, tech neck, sitting at home, being on a computer for long periods of time, and texting a lot, being on their phone can cause a tremendous amount of discomfort, once again, in the fascia. So what are we really talking about when we're talking about managing patients with pain? I mean, obviously, one of the major theories of pain, which was developed by two physicians, Ronald Malzak and Patrick David Wall, who won the Nobel Prize in medicine back in the early 60s for their Malzak-Wall theory. And they've written a wonderful book that you should all have in your library called The Puzzle of Pain, where they talk about how pain is perceived by the body. And their ultimate feeling was, their theory was, that there are gates that open and close and allow for pain from the periphery or from wherever the origin of that pain is to travel to the brain. And when these gates are open, it can manifest in a number of different clinical settings in the patient. And the idea is to find tools, and in this case, we're talking about non-invasive tools or drugless types of tools that can basically close the gate. And Janet Travell talks a lot about this in some of her papers, how she felt that using myofascial pain syndrome techniques and muscle scraping and some of the other things we're going to talk about can be very, very effective in managing patients' pain. What's interesting, when you do a literature search, there's not a lot of articles, unfortunately, written by chiropractors talking about trigger point therapy and myofascial pain. When I was in chiropractic school, I spent a lot of time reading osteopathic journals, the American Journal of Osteopathic Medicine, and there certainly is a wealth of information about myofascial pain syndrome, trigger point therapy. This is just one article that talks about what trigger points are, how they're these hypermobile, very tender points in fascia that, when touched, can cause pain. And that's why they're called, they refer pain. That's why they're called trigger points. They can trigger off pain in other parts of the body. And we're going to talk about the two basic types of trigger points. I just found it interesting that within the chiropractic profession, there's not a lot of documentation about myofascial pain syndrome. So what we're talking about in terms of healing patients and dealing with patients in pain is to move them from the injury of their pain and get them to or follow through the inflammatory pathway and ultimately get to homeostasis. And if that process does not take place properly, then you have ongoing long-term inflammation and ultimately what's now referred to in the literature as inflammaging. So whenever there's an injury to tissue, and in the case of myofascial pain syndrome, we're talking about the fascia, but you can talk about trigger points found in tendons and over the attachment of muscles in certain areas that become very hypermobile. I always try to explain to my patients, it's almost like you go to the store and you buy something that is wrapped up with cellophane, you open it up, and when you close it up again, it's not as slick as it should be, that there are wrinkles in the cellophane, and that's really what you're palpating when you're evaluating a patient. And of course, when the inflammatory process, the injury is not resolved properly, you can start then to develop neuropathic pain and changes in the perception of pain and ultimately chronic inflammation because these gates have not been closed effectively. So we're really trying to take the patient from injury and ultimately to healing. And that's really the whole process of resolution of inflammation. So we should know that obviously there are many different factors that contribute to persistent pain in patients. So there are two types of patients you're going to see in your office who have trigger points, one that have acute or active trigger points, and then there are patients who will present with myofascial types of pain over long periods of time that are called latent trigger points. So in the acute phase, they're active. Long term, they're referred to as latent. And it's really having to do with the degree of inflammation and how effectively the patient has dealt with, I should say the physician has dealt with resolution. So we can see from going from acute inflammation and what happens when we lead to chronic inflammation. And certainly all of the things that patients are coming to your office with fall under this category of chronic inflammation. Now we know that basically everything that's going on in one way, shape, or form has to deal with inflammation or unresolved inflammation, whether it's cardiovascular disease, rheumatoid arthritis, which is an autoimmune disease, other forms of autoimmune disease, neurological disease, cancer, etc. It's chronic inflammation that may manifest itself as myofascial pain syndrome. So let's talk a little bit about this whole thing called inflammation. And certainly if we're going to talk about, we're telling patients that their tissue or whatever they're presenting with, they have inflammation, we should understand exactly what's going on. And the inflammatory process is a very specific organization of cells working together to move from the initial phases of inflammation to resolution. So whenever there's damage to tissue, there's going to be signals that are sent to blood vessels, to the underlying small blood vessels, and those blood vessels will attract what are called adhesion molecules. And those adhesion molecules will then draw in a type of white blood cell called a neutrophil. So neutrophil's job is to kill off anything that's going on. If it's not a pathogen, and in this case, we're not talking about viruses or fungi or bacteria, we're talking about tissue injury. It's the job of neutrophils to initially phagocytose all of the debris that's in that tissue. Now, at some point in time, those neutrophils have to call in or signal macrophages to come in. So macrophages are the real destroyers of this inflammation that's going to happen and to properly engulf the tissue damage. Now, when that happens, that requires a period of time of at least 6 or 8 hours to take place in a well-orchestrated progression of things, meaning there's trauma to the tissue. Neutrophils are called in to try and clean up the debris, what's ever causing the injury. Neutrophils have to signal macrophages. Macrophages come in, they phagocytose everything that's in that tissue. They take it through the lymph nodes, through the lymph system, to the lymph nodes, and in the lymph nodes, it's presented to the lymph nodes to determine what type of immune response is going to happen. So during that process, we're going to talk about things that we can do, and hopefully things that you've been doing already in your practice, whether it's using ice therapy, mobilization techniques, physical therapy, We'll talk about several that have been shown to be effective in treating myofascial pain. But the whole scenario is to get this done in a set period of time. Because if you don't resolve the inflammation that's going on with your patient, they're going to have non-resolution. There's going to be infiltration of neutrophils. So the infiltration of the neutrophils is what causes the swelling. And when you don't get rid of these neutrophils appropriately, you tend to have the patient with, or who could develop not only chronic pain, but will develop these trigger points. And this is really under the control of an important nutrient that is key to signaling this. And that is, these are omega-3 fatty acids. So omega-3 fatty acids, which we know help to reduce inflammation, their job is to signal, or they get released from cell membranes when there's trauma. And the job of this is to help resolve inflammation. Now, many of us use fish oil in our practice as an anti-inflammatory, and we know that fish oil is usually made up of two major components, EPA and DHA. It's the EPA, the eicosanopentanoic acid component of the fish oil, that is designed specifically for reducing inflammation. That's why when you make a recommendation to a patient and you look at the makeup, you always want to have more EPA in the product that you're giving the patient. Now, EPA is naturally found in cell membranes, and it gets released in response to inflammation, the trauma to the tissue. Now, there are ways now that are available that you can do in your office that you can measure the omega-3 levels in tissue of your patients. This is a very inexpensive test. It's a skin prick test. So you prick the person's skin, they bleed, you put it on a block of paper, it gets sent to the lab, and it will give you your omega-3 index. Now, the higher the number, the better it is for the patient. The highest usually is found in Japan because they eat a tremendously high amount of fish at about a level of 8. Most patients that I've seen in my practice are 2 or 3. I've had one patient that scores an 8. So what does that signify? That the patient is not either eating in their diet enough fish, cold water fish, or they don't have enough reserve of fish oil. And once again, the importance of fish oil is to help in the resolution of inflammation. We're going to talk about, when we talk about nutrition, a nutrient that is even more powerful than fish oil. But I just wanted you to keep that in mind in the whole process of inflammation. And this is a much fancier chart looking at what takes place in tissue when there is an inflammatory response, going from, as I said, neutrophil recruitment, macrophage recruitment, taking the information to lymph nodes, getting some type of T cell response, depending upon the type of injury. And we always want to go towards a Th1, a thymus-dependent Th1 type of situation in a patient, because Th1 signifies anti-inflammation as opposed to a Th2 type of response. And once again, what's important is to get to resolution, breaking down the tissue, promote healing, increase the blood supply to the area, and return the tissue to a state of homeostasis. And this is just a chart that shows how initially, if you were to look over hours or days, how initially edema takes place. The edema is really the result of neutrophils entering the area, and then macrophages needing to come in, resolve what's happening, and return the tissue back to normal. So that's kind of an overview. What's important is understanding as you move forward in your reading that there are two different types of macrophages that the body can produce. One that is delineated as an M1 macrophage. And what M1 macrophages are, they're very pro-inflammatory as opposed to M2 types of macrophages. So this comes into big play when we talk about body inflammation, because when there's enough inflammation in the body, there ultimately will be neuroinflammation and neurodegeneration. And understanding how to balance M1 and M2 seems to be the way we want to go. I just want to make a recommendation. If you could try, if you do have comments or anything, if there's a way to talk to Dr. Horn, as opposed to putting it in the chat box, because it's a little disturbing. Okay, so what are we talking about? So myofascial pain is a condition that affects the fascia. It's the connective tissue that covers muscles. The pain can be regional, acute, or chronic. And a physical finding is obviously the trigger point. Myofascial trigger points are hyper-irritable areas with a taut band of skeletal muscle located in the muscular tissue and associated fascia. So I want to show a brief video. I hope Dr. Horn knows how to activate this, because
Which video are you looking for?
the myofascial pain.
Trigger points are caused by muscle injury. Muscles can be injured suddenly in accidents, or damage can occur slowly, due to repeated movements or poor posture. A muscle is composed of tiny fibers, which contract and relax in response to messages from the brain. When muscle fibers become injured or overstimulated, they cannot relax and form contraction knots. A trigger point consists of many contraction knots, where individual muscle fibers contract and cannot relax. Fibers, extending from the trigger point to the muscle attachments shorten, and form a tight band. The persistent contraction of muscle fibers compresses blood vessels and decreases their blood supply, leading to oxygen starvation and the accumulation of waste products. This irritates nerves and causes pain. Activated pain receptors generate specific referred pain patterns, depending on nerve passage and muscle anatomy.
So what's interesting about that video, and we've probably all seen that in practice, even though they're called, trigger points, and we have an expectation when we palpate a patient and we find a trigger point. And what I was always taught, or what Dr. Nimmo and Dr. Travell always talked about, you should be using about as much force when you're doing your examination that you would use if you would have put pressure on your eyeball. So it's not a lot of pressure, and I'm certainly, for the doctors who are doing it, and it looks like a lot of doctors in the audience are doing myofascial technique, you can usually tell the minute you find a trigger point. I mean, not only will the patient tell you that it's a very tender spot, but you can feel the difference in the surrounding tissue. And as I said, there were two different types of trigger points. There's an active trigger point. That's an area of extreme tenderness that usually lies within the skeleton muscle, and it usually has an associated with local or regional pain. And then you have latent trigger points. That's a dominant inactive area that has a potential to act like a trigger point. So lots of times patients will come in, obviously in acute trauma. Those are the easy patients to kind of find where their trigger points are. It's when you're dealing with the much more chronic pain patient who might come in with something totally different, and when they may not actually have any symptoms in that area, but you start doing a mapping of that area and you start to locate these trigger points so that you begin to understand that these can trigger off pain. I mean, I've had situations evaluating patients in the upper extremities, and they'll tell me they're feeling sensation in their lower extremities. So I think it's more or less the kind of scenario you find what you treat. So this basically shows when a muscle goes into spasm or a muscle's been traumatized, that there is an interaction that takes place where there's a supply of information coming from the muscle to the spinal cord up to the brain, and it's coming the other way around from the brain through back to the muscle cells, causing this arc of pain and inflammation. So this is a checklist that you can use. I'm very big in my office about having checklists, giving patients forms to fill out where you can get a good idea of what's going on. I would say, I give this to every patient, as well as giving them a metabolic screening questionnaire. A metabolic screening questionnaire was developed by Jeffrey Bland. How many doctors in the room are familiar with a metabolic screening questionnaire? A couple. So metabolic screening questionnaire is an inventory by systems. You can kind of get a good idea of what's going on with your patient, secondary to the pain that they came in with. But you can look at these. Your pain is generally dull, aching, or nagging. Your pain feels more like it's in a muscle than in a joint. Seems very deep. Affected limbs may feel a little weak. So this is a good, and if people want a copy of this, you can always contact Dr. Horn. I'll be more than happy to send you a copy of this particular form, as well as a metabolic screening questionnaire. I built my whole practice on using this form on every patient that came into my office, and a metabolic screening questionnaire, just to see what was happening with them metabolically, and basically looking at their overall level of toxicity. So this is a good way to get an understanding when the patient comes in, because I think it's interesting that if they've been to other chiropractors who don't, I mean, it's amazing how many patients have come to me. I've had patients come to me and they say that the chiropractor didn't even touch them because they're doing some other technique that's not using their hands. All I can tell you is that we do something so unique by touching people, that touching is so important. Now, the reason I put this slide on, because this is a slide that's taken from that app that you can find in the Apple Store. I think it's $1.99, and you can see it has if you find it, it'll be like the second or third app in the App Store as it relates to trigger points. And I have this on my iPad, as I said. So when patients come in, you can show them exactly where the trigger points are, but more importantly, where patients can refer their pain. And this is a very helpful. I will try, unless somebody wants to know the name of the app. I think it's called the Trigger Point app. I know that sounds a little weird, but when you go to the App Store, I think it's the second or third app under trigger points, and you'll see the coloring very similar to this slide. And I believe it's $1.99. It's not an expensive app, and when you download it, you'll be amazed at the information that's in there to help patients. So the reason it's called a trigger point is because it triggers off pain. It sets off a pain pattern which is specific to each trigger point. So we know if you're doing trigger point work and you look up in any trigger point book that you find, that there should be a referred pain pattern to that specific trigger point. But you should understand that that's not always the case. So this is a chart that's taken really from a paper on fibromyalgia. In fibromyalgia, they specifically look at these 14 major trigger points in the body. And this is a good starting point for practitioners who probably have not done any myofascial pain work or trigger point therapy to at least become comfortable with trying to find these different trigger points. One of the doctors was nice enough to say, it's $2.99, so I apologize. It must have gone up in so many years that I bought it because it was $1.99. And like I said, this is an excellent, excellent tool to help educate your patients as to what you're doing and why they're feeling what they're feeling. So obviously we know that, or should be aware that myofascial pain syndrome and myofascial trigger points have a number of different, reasons, mechanical as it relates to posture, structural, leg length deficiencies. You're probably all familiar with these. This is an excellent article on myofascial pain syndrome. Certainly, we know the relationship between stress and muscle tension. There are obviously certain medical inflammatory conditions. So in the first part, when I talked about inflammation, obviously, many patients can develop trigger points as a result of either having a bacterial infection, a fungal infection, or a viral infection. Why? Because when a patient is overrun with any of those three different scenarios, it reduces their immune response. And when their immune response goes down, one of the things that can happen is it can elicit pain patterns that can manifest ultimately as myofascial pain syndrome. Metabolically, there's a whole host of nutrients. We won't be able to get to all of them, but that's a really good look. Vitamin B1. And in particular, when I talk about B1, we're going to be talking about fat-soluble B1. So B vitamins are water-soluble for the most part, which means what the body doesn't use, the body urinates out, except for fat-soluble B1. There's a lot of interest in fat-soluble B1, benfotiamine, and what benfotiamine is needed for is not only for the metabolism of carbohydrates, but for proper nerve functioning. So once again, this is not your normal thiamine that you would find in a B vitamin. This is fat-soluble B1. And there's a lot of work that's out there on the use of B1 for neuropathic pain, which is very commonly found in patients that have myofascial pain. Obviously, all of the B vitamins, especially B6 and B12, because of its relationship to methylation, vitamin C to reduce inflammation. We're going to talk later about the role of vitamin D. And we'll talk a little bit about magnesium and zinc and the role that that plays in myofascial pain. And of course, psychologically, there is an excellent book that was written several years ago by a practitioner, John Sarnow, Sarno. I don't know, any doctors have read his work, John Sarnow? So John Sarnow felt that most patients who presented to any type of healthcare provider with joint pain or any type of musculoskeletal pain, it had nothing to do with an orthopedic problem. That it was tension in tendons and muscles and ligaments. And his feeling was to try and identify in those patients what was the precipitating factor at the point in time that a patient started to develop chronic pain. And he found that by looking at how people respond to stress, and we should always remember that patients who are coming to us in pain are dealing with stress. And how does stress impact inflammation? And how does stress impact GI function. And that's why it's so important, I think, if you're treating patients from a nutritional perspective who have any type of musculoskeletal complaint, to always investigate what's going on in the gut and whether or not there's gut barrier dysfunction. We used to call it intestinal permeability, but now we talk about gut barrier dysfunction, and understand that there's gut barrier dysfunction, blood-brain barrier dysfunction, and lung dysfunction in terms of the barriers in the lungs. So all of this is important to keep in mind when you're treating a patient. Now, this is just a classification that's taken from a paper that looks at local pain, regional pain, and generalized pain. And myofascial pain syndrome is considered a regional pain type of scenario. These are all things you can use in your practice in terms of understanding and examining the patient. You can look at these slides on your own. And this is a really good way to, when you're doing your assessment on a patient, where they're feeling their pain and to what degree of pain they have. It's a rating scale of 0 to 5. You know, do they have the pain some of the time? Is it increased with movement? You're all probably familiar with all of these pain grading systems. So myofascial pain syndrome and trigger points. So Dr. Horn, the second video. Are you there?
Yes, give me just a moment here.
Okay.
I'm not sure if we have that one, Doc. Could we, what's off? We have myofascial pain syndrome, Babel coolant, and foam relief.
Yes.
Okay, so which of those four do you want?
It's the foam rolling one.
Okay, good deal.
Between the skin and muscle, there's a layer of fibrous connective tissue called fascia. The fascial layer is a sheet of connective tissue fibers composed primarily of collagen that forms beneath the skin to stabilize and anchor muscles and other internal structures. In a healthy system, the muscle will slide and move without restriction. When a muscle becomes injured, the rate of collagen product by local fibroblasts is increased. The fascia becomes extra dense and facial adhesions are created. Overproduction of fascial adhesions can affect mobility of corresponding muscles and joints. Fascial mobilization helps release or loosen fascial adhesions in order to promote healthy range of motion and prevent injury.
Okay, I am no way promoting that particular product. When I was looking at videos, I found that and I thought it was a pretty good video to get its point across. But when we're looking at a trigger point per se, these are painful on compression. And as I said, you should use about as much pressure as pressing on your eyeball. They can invoke characteristic referred pain or pain just localized in the area. And it will be a band. You will be able to feel it for those of you who may be newcomers to treating trigger points or myofascial pain. So a trigger point can be activated by overload, overwork fatigue, trauma, cold, postural strains, disuse syndromes, and indirectly by other trigger points. So it's not unusual to find patients with multiple trigger points, visceral disease, arthritic joints, emotional distress or stress can activate trigger points. And this is basically a repeat of something I've showed before, that when there's stimulation to the tissue and it sends a message to the brain, you will get the referred pain that's often found in these patients. Once again, you don't have to get the referred pain, but in most patients, it's been my experience, they will say they feel it somewhere else. And that's why the Trigger Point app is, I think, very helpful to explain to the patient. Here we can see, I know when I was in chiropractic school, they would say, put something in, we don't even have them anymore, a telephone book, and see if you could palpate over the several pages in a telephone book or a book, if you could palpate a trigger point and what that would feel like. We would always go to school and say, yeah, we felt that, and go home and say, I have no idea what the doctor is talking about. I had never felt that. But it is an art and a science. And this basically shows you within a muscle that's very tight where the trigger point nodule would be. So an active myofascial trigger point will vary throughout the day. We know this already. If you've been in clinical practice, patients will tell you that it moves around all the time. It doesn't have to be constant, but definitely patients will experience stiffness and restriction in range of motion. So I always looked at it when I was starting in practice that these were patients that came in with restriction in range of motion and in the tissue. And oftentimes, if you muscle test them, they will show weakness in that area. So passive or active stretching is important, improving the range of motion. And of course, you may increase the pain and tenderness, especially when you're palpating the patient. So the unusual thing is there's nothing in laboratory testing or anything that you can do unless you're doing thermograms, but it's one of these concepts that you can't really find a test or anything that you could say positively unless the patient is dealing with some metabolic problem. Even if you were to do inflammatory markers like a SED rate or measuring homocysteine levels or C-reactive protein, most of the time these tests will all be within normal. So there are lots of different tests, techniques that we're going to talk about. How many doctors here do spray and stretch? I'd be curious how many old timers do spray and stretch. A couple. Wow, that's great, because that's how I started to treat patients. Obviously, the use of heat, which is not really that conducive per se in treating. It's been my experience. Obviously, we don't get into injections. The use of ultrasound, acupuncture. And these are just a list of some of the other things that can be used. Obviously, I have in my practice a grade 4 Colite laser, which I find very effective. Ultrasound, transcutaneous electrical nerve stimulation, and we'll talk about all of these. So obviously, myofascial pain can be used to treat a number of different conditions. I find it very effective in not only lower back pain, but obviously muscle tension types of headaches. We've all experienced that. And I'm going to be hopefully doing in a couple of months, we're going to do a webinar on temporomandibular joint dysfunction. I find that obviously trigger points in the masseter muscle and internal massage of the trigger points can be very helpful in treating these patients. And my experience has been any patient that has a occlusion or TMJ type of problem will have a cervical spine problem. So I guess the doctor is saying we need to do these poll questions. So number 1, trigger points are usually located soft tissue, joints, heart muscle, arteries, or veins. Okay, I think that's 100% of people recorded. And the right answer, of course, is soft tissue. Are we going to take the second poll question now, or? Okay, trigger points are active all the time. True or false? Okay, and the correct answer is, of course, false. They're not active all the time. Patients probably don't even know they have trigger points until they come to your office and you start to do your evaluation. So once again, this is a, yeah, I can hardly hear you. You want to take a break?
Yes, let's go ahead and take a break for about 10 minutes.
Okay, so we'll be back at 9 o'clock.
And Dr. Howard, I noticed we have Dr. Paul has a question for you in the
Right, I was just going to answer that.
Great.
So that was a slide that I took from another presentation. Certainly what the question is from the doctor is, the slide mentioned is the use of heat. Now, obviously, we know, so that slide needs to be changed. So I'm glad you caught the error. And in fact, that's one of my poll questions, that the best treatment over a trigger point or any type of inflammatory scenario is to use ice over the area. So I'm glad you caught that error. I have to go back and change that slide. Ice is certainly the proper indication to reduce pain and inflammation and swelling, not to use heat. I always advise patients they can take a warm shower, steam, sauna, whatever, but no direct heat. So the first thing I want to talk about, as I said, I don't know how many doctors do this. When I was introduced to myofascial pain techniques, was something called spray and stretch. And what spray and stretch is, and you can read for yourself, stretching is the action, but you're spraying a vasocoolant spray over the muscle. So here you're treating the lower fibers of the trapezius. The patient is sitting down, bending forward, and you're spraying. So there's one company that makes this, which seems hard to imagine, Gibauer. I believe they're in Cleveland, Ohio, and they make two products. One is called ethyl chloride, and the other is fluoromethane. Ethyl chloride is if you go and watch a baseball game or some sports game, and the person gets hit by a foul ball or something happens, they immediately spray this to reduce any inflammation. The problem is it's much too cold to spray on tissue. And that's why they developed, or Janet Travell, Dr. Travell developed fluoromethane spray. Now, to show you, since we are in an era of inflation, when I first got into practice, a bottle of spray and stretch, and that's what it's called, fluoromethane, was, I believe, $4. The last time I checked about 2 weeks ago to order, it's about $70. Any doctors in the audience do spray and stretch? This is an excellent tool for dealing with patients who come into your office. I only see a couple of hands, so hopefully some of you might get interested in including this in your treatment protocol. But this is exceptional therapy for patients who come in with not only acute pain, but let's say torticollis, spasm. There's no good range of motion. There's tightness in their hamstring muscles, quad muscles, etc. So you're stretching the muscle and spraying it at the same time. So this is what the product looks like. A lot different when I bought it. And like I said, this is the only company that I know of, unless somebody else knows of a different company or another product that they use for doing spray and stretch. But this is the only product that I know that's in existence to do this. So the sudden drop in skin temperature is thought to produce the temporary anesthesia, and decreasing the pain sensation allows the muscle to be passively stretched, which helps inactive trigger points relieve muscle spasm. So I think, yes, video on vasocoolant spray. Dr. Horn.
Identify the trigger points and related tight muscles. Position the patient comfortably. Protect the surroundings for ethyl chloride, or with fluoromethane, no need for protection in the surrounding tissues. Ensure that the patient's eyes are protected. Hold the bottle about 45 centimeters or 18 inches from the skin. Apply the spray at 10 centimeters per second and hit the skin at a 30-degree angle. After the spray, have patients stretch while exhaling and rewarm the tissue with more, followed by active range of motion exercises.
Okay, so I do my spray and stretch a lot differently than that practitioner. As I'm spraying the muscle, I'm stretching it at the same time. This practitioner was spraying the muscle, afterwards stretching it, and once again, he was using heat. My reason for showing that video was just to show. I mean, it's very hard to find very short videos if you go on YouTube, because they usually go on for minutes and minutes and minutes of showing something. But I think you have a good idea of the technique. One of the doctors noted that her daughter has IT band tightness, and using a spray and stretch technique is a phenomenal way to stretch out the muscle, and at the same time you're spraying it. All I can tell you, this can be a game changer for your patients. And especially, like I said, if you treat a lot of runners, this is quite common to experience lower extremity trigger points, starting all the way down from the SI joints and using spray and stretch. I don't do it as much as I used to do it, and I really want to get back to doing it because I really spend more of my time treating trigger points with a scraping tool, which we'll talk about, and really using my hands after so many years. So obviously, one of the things that's come to the mainstream in treating myofascial pain is doing some type of instrument-assisted soft tissue mobilization, as it's referred to. I mean, the Chinese call it gua sha. It's called muscle scraping. And this is probably the hallmark for doctors doing any type of trigger point work: locating the trigger point, seeing if the trigger point radiates. If you don't want to have the expense of buying the fluoromethane, then you're into the domain of using your hands or some type of tool to use it. I mean, this has become popularized by Graston technique. Are there practitioners in the audience that do Graston technique or are certified in Graston? Graston has been an extension of really myofascial pain. The big difference is, obviously it's much more detailed. And of course, you're buying a lot more instruments. I'll show you just one of the instruments that I use, but there certainly is a lot of literature about the benefits of using a scraping type of tool. I know I had a massage therapist in my office many moons ago that just used a spoon to do her muscle scraping, which I thought was a little barbaric. But instrument-assisted soft tissue has been shown to be very, very effective in treating trigger points. So the picture on the left is one of the tools that I use for trigger point therapy. And I had originally purchased a set of tools from a chiropractor in South Dakota, whose father was a tool and die maker who made, I believe the name of the product, the company was Smart Tools, and it was really only two types of instrumentation. I mean, you can buy instruments at all different price ranges. I just purchased one a little smaller than in that picture. I think I paid $20 for it on Amazon. But I always had a problem in getting the right texture of cream, because you can't do this unless you have some type of cream on the surface of the skin. And on the right side, so I finally called this guy up in South Dakota. I said, "What are you using? I've tried so many different things." And he developed this particular cream to be used with myofascial pain using any type of instrument-assisted soft tissue technique. And that's what I use in my practice. It's put out by Biotone. I mean, it's very popular they have their own website in massage clinics. And to me, it was like, why should I recreate the wheel when he's used it? I have found it to be very, very effective. That's what I use when I'm using a tool. I think because I'm such an old timer, what Nimmo taught us is just use your fingers, your hands, your elbows, the tips of your elbows, whatever you can find. I mean, this was much sooner in the game before these tools were created. So let's show the slide of doing gua sha.
Are we going?
Yeah.
All right. This is the infamous Jeremy Scott. I'm Dr. Brian Geyer. We're going to do a little gua sha therapy to help improve Jeremy's rhomboid and mid and low trap area, loosen up the neck and the pec. I'm just going to take this arm across your chest and just kind of take some deep breaths in.
That's crazy.
So right in here, Jeremy had a pulled muscle, a rib out, and we're basically anywhere you see the red petechial reaction is where he had scar tissue or connective tissue that was basically compressing the blood flow and some of the nerve endings. So we're just going to release the connective tissue and get his normal function back in his muscles and his nerves. It's not the most comfortable in him, Jeremy.
Yeah, that sucks. Wow, here it comes.
Wow. So rad.
So you can see This is purplish.
Yeah.
That is indicative of a little bit longer, more like a chronic 1 month, 2 month, or longer type of injury. Bright red is acute, purpley, more chronic. So there you have it. Good job.
Okay, so obviously my comment about that would be, before you go ahead and do this, you need to explain to the patient that there might be some redness and swelling over the area. I remember a couple of years ago seeing this done on television. And the person looked like they were dragged by a truck because they were so black and blue. I mean, obviously do no harm. And depending upon a lot of different factors, especially if the person is very light-skinned, you should know that there's going to be that type of reaction. I mean, I do it a little differently. I'm a little more aggressive with the scraping because I find that that's what people want. And this is going to be the type of thing that's obviously not going to go away 1, 2, 3. It's going to take several sessions. But what you're going to find out when you're in practice, that these patients are going to continually present with these latent trigger points. And when they do have an episode or a flare up, you know exactly where to go and where to treat them and how you want to go about treating them. I mean, obviously, you can do it hands-on. You can do it with a tool. How many doctors use tools in their practice? I'm just trying to get an idea. Okay. I mean, the one thing, obviously, with this type of technique is it takes a lot of time working on patients, and but the results that you're going to see are going to be amazing. So obviously, we can use ultrasound in the area, high frequency sound. If I knew what I knew now after 40-something years of practice, I probably would not have an ultrasound unit. I wouldn't have a muscle stim unit. I would only have a cold-light laser unit in my practice because I think it's the most effective. But certainly we should all be familiar with the fact that ultrasound can be effective. The only problem is it's an attended type of therapy. You have to be there or have someone doing it. I'm not sure the legality of that in every state. I know in New York State, you no longer can have a chiropractic assistant doing ultrasound. It's a one-on-one, hands-on. So that does require time, and you have to be there with the patient. So depending upon how you run your practice, I mean, my practice is very one-on-one. I don't overbook a lot of patients. I tend to want to spend a lot of time with patients to get the results that I think they should get. So ultrasound is definitely good. I mean, you can use transcutaneous electrical nerve stim. I mean, TENS treatment is something that early on I got involved doing. But I really found out that by doing more and more research, that unless you're very specific with the placements of your pads, I didn't see the patient getting a good result. I would think you would get better results, and I have gotten better results with an EMS unit. So the only time I use TENS in my practice is that there's been a lot of research now on stimulating the vagus nerve using transcutaneous vagal nerve stimulation, where you're attaching the TENS unit to the tragus of the left ear. And this seems to be very effective. I mention it because I think that it's very difficult. I don't know how many other doctors agree. I don't find good results with using a TENS unit for musculoskeletal pain. It's just not very specific, and you really have to be right on. So transcutaneous there are studies that look at the efficacy of it and say it is valuable. To me, I find the best thing. How many doctors in the audience have a laser, cold-light laser? I mean, I found out the hard way about 15, 20 years ago, fell off a ladder, broke my radius and ulnar. And when I came out of the cast, I was in so much pain, I don't know how I was going to be able to practice, I started to investigate lasers. I had called a detail guy who came to my office and basically told me he felt in 5 minutes that he could get rid of my pain that I had. And sure enough, in about 5 minutes, most of my pain was gone. And that was a level 3. So you can understand how long ago that was. Now they're a grade 4. And what I find now, this is the laser that I have, an MR4 multi-radiance laser, that you can be very specific over an area. I always explain to patients there's good news and bad news. The good news is it works incredibly well. The bad news is they don't feel anything. So it's not like if they're doing ultrasound, you're doing muscle stem, but you can really get into an area where there's inflammation because the laser has an ultrasound unit in there that will pick up where the localization of these trigger points are. And usually treatment time is anywhere from 5 to 10 minutes over an area. That's usually my protocol in my office. And I mean, obviously, from my understanding, insurance companies don't cover laser treatment. So it's the kind of thing that either you charge the patient or you include it in their office visit. I just find it to be a really interesting protocol. It's helped me and continues to help me, and it's been shown. And certainly there are websites where you can go and actually take classes in learning how to use the laser for a number of different conditions. And I think cold-light laser therapy is a very, very powerful adjunctive tool. So the evaluation of the effects of intravenous and percutaneous low-level laser therapy. So there's lots of research coming out about laser therapy and the benefits of using laser over an area. So we know that it has a number of different effects on the body. It changes or alters the gait control theory. It helps to stimulate the release of endorphins. It improves circulation to an area. It helps to get rid of debris. It inhibits the production of these inflammatory cytokines, and in particular, TNF alpha and NF kappa B also. And it helps with vasodilation and dissociation of tissue in an area that's been traumatized. So cold-light laser therapy can be very, very active, can be very, very helpful. Now, usually very involved in the diagnosis of myofascial pain syndrome or trigger point therapy is fibromyalgia. And as I said, fibromyalgia now has become very, very in mainstream because they're finding a lot of patients who have had COVID-19 seem to have been developing not only fibromyalgia, but MS. And a lot of this has to do with how the immune system is being affected by the SARS-CoV-2 virus. So if you just look at the numbers of the cost of what's involved with treating patients, and fibromyalgic patients are and chronic fatigue patients and myofascial pain syndrome patients are very difficult to treat because there's always a lot of underlying problems. And this is where you can build an incredible practice just by talking to your patients and finding out a lot of different things. I mean, I always do the metabolic screening questionnaire and talk to my patients about, obviously, diet and nutrition and stress. And I certainly invite you, if you haven't, to go back into the webinars that I've posted specifically as it relates to managing inflammation and managing stress and seeing how alterations of the HPA axis, and in particular elevations of cortisol and low DHEA, play a profound impact on patients dealing with pain and patients with myofascial pain syndrome. So there are obviously lots of different physical and psychological factors. We know that when there is a maladaptive stress response or maladaptive HPA axis effect, which drives the sympathetic nervous system, there is going to be a problem then with the parasympathetic nervous system, because these patients are usually sympathetic dominant. So think of it as the sympathetic nervous system, where the fight and flight response is being driven by cortisol, and the parasympathetic nervous system, which is driven by acetylcholine, is the rest and digest. So obviously, most patients coming to your office are not only in pain, but they're maladapting to stress. And that's why it's so important to consider stress evaluation or adrenal function. I don't like to use that word because that's being phased out, that patients have an adrenal problem. It's more about their HPA axis, the hypothalamic pituitary adrenal axis, and that how that affects their overall pain. And this is a clinical chart that kind of shows the difference between myofascial pain syndrome and fibromyalgia. Remember, I said for the most part, it's more about patients with fibromyalgia having more anxiety, more, and definitely fatigue, and much more issues with sleep disturbance. And that there's a whole new looking at the patient's circadian rhythm. So this is not simply patient comes in, you see them, you evaluate them for myofascial pain syndrome or trigger points, you start doing this technique. If you want to get better, longer lasting results, start to span out and look at some of these other factors about their immune system, their endocrine system, their musculoskeletal system. And as I said, how does the gut talk to the nervous system? Through this enteric nervous system, gut brain, which I think is very foremost in the minds of a lot of researchers now, and looking at how the gut interacts with the brain, and more importantly, does gut function, what part does that play in neuroinflammation and ultimately neurodegeneration? So here you can see a comparison between fibromyalgia and myofascial pain syndrome. 9 million Americans, 30% of pain-related visits to a general internal medicine office can be attributed to myofascial pain. How much money is spent, and there doesn't seem to be any difference between men and women as it relates to myofascial pain, and it's positively correlated with age. So let's start to talk about some of the nutrients that might be helpful. I'm going to start off with the vitamin that has seen in the last 2 years an overwhelming amount of information about it as it relates to the immune system. But vitamin D, it's moved away from this vitamin, and it's actually a hormone, but it's kind of moved away from its primary kind of conversation as it relates to bone health into looking at a number of different things that it may be effective in treating. Personally, for me, it's my go-to vitamin for pain management. But at the same time, and I'm going to make the statement that I've gotten from a lot of other practitioners, that every part of a person's immune system, whether it's their innate immune response or their adaptive immune response, is totally dependent on vitamin D. And I think vitamin D, if you're not checking it, you're missing the boat. This can be done also in your office with a skin prick. Certainly, studies have looked at the importance of vitamin D in general health and wellness, since we know now that anywhere from 40 to 70% of the world's population is vitamin D deficient. So you almost have to assume that patients are deficient in vitamin D, and supplementing accordingly. Now, the one thing you can't get into is testing a patient and then testing them over and over and over again. I usually test my patients once every year to see how they're responding to vitamin D, more than just looking at vitamin D reducing their pain and inflammation. You can't get into over testing, and you have to be consistent with the testing and make sure the lab is testing what it's supposed to be testing, which is 25 hydroxy vitamin D, not the 125. A lot of labs do 125 dihydroxy vitamin D. That's not the vitamin D that you should be measuring. You should be measuring the 25 hydroxy vitamin D and make your recommendations accordingly. I mean, I've used up to 10,000 IUs a day. I personally take 5,000 units a day. I think what's interesting is how more and more papers have come out looking at low levels of vitamin D in healthcare providers. The show of hands, how many doctors in the room take vitamin D? Not 100%, but I certainly think that this is a crucial, important nutrient. And vitamin D with K2 seems to be the way to go, or using vitamin D in a liposomal delivery system. So liposomal delivery systems are becoming very popular now as it relates to the delivery of vitamins and minerals. There's liposomal vitamin C, liposomal glutathione, liposomal vitamin D, liposomal magnesium is crucial. What does liposomal mean? So liposomal means that whatever you're trying to deliver, in this case, vitamin D, is encapsulated in a lipid base so that it's much easier for absorbability. And certainly, like I said, 5,000 units of vitamin D a day. I know that personally, my vitamin D level is 57 nanograms per milliliter, which is kind of up there. What the studies show now is that vitamin D at about the level of 32 nanograms per milliliter is probably when you're moving away from deficiency and dependency into much higher ranges. So you want to try and get your patients into that range. You'd be amazed. The lowest I've ever seen in my practice was 8 nanograms per milliliter in a woman who had rheumatoid arthritis, a tremendous improvement in her symptoms with getting her vitamin D levels into the 40 and 50 range. So I think vitamin D is one of those very important nutrients, not only for the immune system. As I said, it affects not only the innate immune response, but it also affects the adaptive immune response, because it plays a very big role in determining how T cells proliferate and what type of T cells you're getting, whether it's a Th1 dominant scenario, which is a much more homeostatic anti-inflammatory, versus a Th2 dominant scenario in a patient, which is a much more aggressive, which usually means that the patient has an infection or inflammation in hollow spaces. So these are patients who present with lung problems, asthma, allergies, sinusitis, colitis, bladder issues. And the important part about that is Th2 dominant patients lead into autoimmune types of diseases. So vitamin D is definitely shown to be helpful in a number of different things. And here's a chart that looks at the different actions of what vitamin D has on the immune system, as far as its effects on various types of T cells, antimicrobial peptides, which is a big part of the innate immune response, meaning it's covering the surface of the epithelial lining of the GI tract, where the body produces mucus. It reduces prostaglandin E2. It reduces tumor necrosis factor alpha, TNF alpha, which is a transcription factor for inflammation. So magnesium and pain and muscle spasm, if you're not seeing patients that are vitamin D deficient, you're definitely seeing patients that are magnesium deficient. Magnesium is a natural muscle relaxer. The only issue is if you give a patient too much magnesium, they'll get diarrhea. So it's usually important to know the different types of magnesium that are available. I usually use magnesium glycinate, and usually anywhere from 200 to 400 milligrams a day is sufficient. When you start getting into magnesium orotate or even magnesium aspartate, sometimes these are the forms of magnesium that a patient might have a negative response to. There is another form of magnesium called magnesium threonate. And magnesium threonate is the only form of magnesium that is able to cross the blood-brain barrier and is very effective in patients with cognitive decline, fatigue, anxiety, and depression using magnesium threonate. And I think the trade name or copyrighted name of it is MAG10, MAGTEIN. And most vitamin companies will sell magnesium threonate. But remember, that's the only form for the use of myofascial pain syndrome. I use magnesium glycinate or magnesium citrate. And as I said, 200 to 400 milligrams a day. So magnesium deficiencies would imply muscle pain, spasms, chronic pain, numbness and tingling, insomnia, chronic fatigue. I mean, you can measure RBC levels of magnesium. You can't measure serum levels because it's not a good indicator of magnesium. So you have to tell the lab you want an RBC magnesium level if you are suspicious of this being the case in your patient. And as I said, magnesium glycinate, it works very, very quickly. 200 to 400 milligrams a day. So this is a supplement that I've gotten interested in the last few years. It's called palmitoyl ethanolamide, or PEA. So palmitoyl ethanolamide is a group of nutrients that fall into the category of ethanol amides. And these are very similar to something I'm going to talk about that is found in cell membranes. And it is released in response to inflammation. And PEA has been shown to be effective in a wide variety of clinical situations. I found out about it by doing some research on inflammation. I was really head over heels in understanding the inflammatory pathway, all of the different cell mechanisms and cell signaling. And I came across this practitioner in Belgium who ran his entire pain clinic, whether it was sciatica, low back pain, you name it. And he was using this particular nutrient, which is derived from safflower oil, from safflower seeds, the oil. And in the early 40s or so, research showed that egg yolks contained PEA and that the egg yolk was an effective tool in reducing inflammation. So I started to try and source this product, which I was lucky to do. There are several companies now that sell PEA. To me, this is my number one thing to go to, along with vitamin D, in dealing with pain. About 2 years ago, I tore my meniscus, my medial meniscus on my right knee, and had to have arthroscopic surgery. And when they did the surgery, they found, after 46 years of standing on a hard floor, I had severe osteoarthritis, and they had to debride the joint. So I basically have on the medial side pain bone rubbing on bone. I'm sure you've seen this all before in your practice. So have I after 46 years. It certainly is a lot different when it's in you. And I started to use PEA. And the recommended dose is 400 milligrams of PEA 3 times a day. And I will say that by using that, I have no pain in my knee. I have used this, and it's interesting, not only in patients with chronic myofascial pain syndrome, but pain syndromes of all different types. And we've used it in with patients on their dogs who have severe arthritis. And there is, depending upon the size of the dog, anywhere from 400 to 800 milligrams. And it seems to work wonders in reducing pain and reducing inflammation. What PEA does, it's one of these nutrients that falls into the category of a pro-resolving mediator. What is a pro-resolving mediator? Well, a pro-resolving mediator, if you remember back when I talked about inflammation, I said within the cell membrane, there's fish oil, omega-3 fatty acids. That omega-3 fatty acid, when it's released, gets hydroxylated into a number of different components, which are called pro-resolving mediators. They were developed or investigated several years ago by a doctor up at Harvard. They are 100 times more anti-inflammatory than fish oil, regardless of the source of your fish oil. And there are vitamin companies that sell SPMs. I was pleasantly surprised when doing a previous webinar. My doctor contacted me to let me know that his wife had just gone through a radical mastectomy. And the physician, the surgeon, recommended SPMs to his wife to start to take. Now, certainly, if you're dealing with patients with chronic pain syndromes, using something like SPM or PEA can be very, very helpful. I have found this to be amazing, and it's more upsetting that more practitioners don't know about palmitoyl ethanol amide, but it is well referenced in not only the veterinary literature, but the medical literature. So you can see how it's been shown to have excellent results in treating lower back pain, osteoarthritis, fibromyalgia, peripheral neuropathies to include diabetic neuropathy, neuropathic pain, chronic pelvic and vaginal pain. What's interesting with chronic pelvic and vaginal pain is research that's shown the effectiveness of vitamin D. And all other types of neuralgias and neuropathies can work very well with using PEA. There is one company, unfortunately, I wish it was easier to source because it comes from Spain, which has liposomal PEA. And if any doctor wants to know the email, the website, you can order it. Liposomal PEA is 20 times more powerful. I actually have to alternate because it's not so easy to get this stuff from Spain. There used to be a distributor in the United States. I don't know why no other vitamin company wants to get into using PEA, but there are several companies that sell PEA, but not liposomal PEA, which is in a liquid form. And it's, I think, a game changer. So what are pro-resolving mediators? As I said, this was discovered by Dr. Charles Sirhan at Harvard Medical School. They are derived from EPA and DHA through a metabolic process in the animal and orchestrates the control of inflammation. So this is what drives resolution of inflammation. PEA and these pro-resolving mediators. And as I said, they are about 100 times more anti-inflammatory than using fish oil. When you look at fish oil, I previously mentioned you have to look at the makeup of how much EPA and how much DHA is in the product, and you want to make sure there's more EPA. But now you have to look at where is the fish oil coming from, meaning it's coming from obviously the livers of fish. Where are the fish caught? How quickly are the fish processed? There's a whole list of chemicals, testing that's done to determine whether or not the fish oil, by the time it gets put in a capsule and is sold, has it turned rancid already. So you really have to do your research in looking at the fish oil. And I know there are a lot of doctors who always ask me about krill oil. I have no experience in using krill oil in my practice at all. I only use either EPA, DHA, or PEA and these pro-resolving mediators. You really need to do your homework if you're recommending fish oil, knowing all of these different things. So this is a breakdown of where these different components of EPA and DHA hydroxylate into. Some of them protect cell membranes, some of them protect nerves, but this is, something that's very, very important in managing patients, whether they're really more in terms of their inflammation has not been resolved. This is just a general slide that shows you all of the different conditions that pro-resolving mediators have been shown to be helpful in. I'm running through this because I'm getting the thing from Dr. Horan that we have to finish to get our other two poll questions. So what I've tried to do, and obviously this is to me, I think a very valuable topic in terms of understanding how you can better treat patients with musculoskeletal pain, number one. Number two, using some of the things we talked about. I mean, to me, I don't do as much spray and stretch as I used to, but certainly using instrument assisted, and for me, using laser, nutritional support for the resolution of inflammation and also as well as reducing inflammation. So, Dr. Horn, you want to put up the next two poll questions? And if any doctors then after that have any questions. Using cold compresses on a trigger point is a good idea. And this is the thing that that I have to fix the slide. So maybe that's a hint. Now I'm going to preface that by saying it's like an ice pack. So it's not very cold per se, because using that, maybe that's giving away the result that I wanted, or the answer that I wanted. Okay, so the answer to that is really you want to use cold on a trigger point. You don't want to use heat to bring more blood into an area. So this question, this important vitamin is actually a hormone. And this is not a trick question. I'm looking for the best answer. Best answer. Don't read too much into it. So the answer I was looking for is vitamin D. So if any doctors have any questions or comments or whatever, Dr. Horn, are you there?
Yes, sir.
I can hear you. So do we have any questions or anything you need to review with the doctors? So a doctor wanted to know about the Trigger Point app. I don't know the name only because I already have it installed. So it's other doctors have said it's $2.99, $2.99. And if you go into as I'm doing right now, into the App Store, it is the second one that shows up if you just type in Trigger Point. It shows the patient's face, their skull, and you can see the blue on it. And it says Muscle Trigger Medical. And according to the other doctors, it's $2.99. So let's see. Okay, please name the 2 books again you recommended. I recommended a couple of books, but certainly if you're interested in pain, it's called The Puzzle of Pain by Melzak and Wall. They're the 2 doctors that did all of the research and published on this whole idea of gait control theory. I also mentioned, obviously, Travell and Simmons, their textbooks, but there are numbers of books on trigger point therapy, because I know the Travell and Simmons book is a little costly. I think both volumes are almost $300, but that is the book of choice. That is the book on trigger points, and it goes into much more detail, but it has some excellent drawings and excellent depictions of doing spray and stretch. Somebody wanted to know more EPA or DHA. More EPA. DHA is more for the brain, for the eyes. EPA is more the anti-inflammatory. But as I said, if you want to get even better than fish oil, pro-resolving mediators. And if you want, Dr. Horn has my email. I can list for you what companies sell pro-resolving mediators if you want to go that route. I will say I really more are using PEA, but in some really difficult chronic patients, I use SPMs. Anything else? Well, I hope you had an overview for those of you who do myofascial pain syndrome work and trigger point work. Great, because I think it is so valuable a technique. For those of you who've come in here wanting to know more, I hope this has whet your appetite a little bit about considering looking for this in different ways you can treat patients clinically. And
thank you for learning with CCED seminars. We're proud to support chiropractors with high-quality continuing education available anytime, anywhere. We look forward to supporting your professional journey. Blessings and success.